Good morning, everyone. Thank you all for coming. We have Dr. Sandra Hansen and Liz Holt from Alina, our Telestroke team. We're very excited to get this training started today and tomorrow and get this program up and running. So Connie will speak on kind of the evaluation forms and where you can get your CEUs, and then we'll let these guys get started.
Sure. The slides for today are posted on the central line and on the desktop folder under education in each one. And there's just a folder of Telestroke slides and handouts. So the handouts and things are there in the slides because there's a lot of slides, and rather than printing them out for everybody. There's extra paper on the tables if you want to take notes on that. Continuing education credit is assigned to you in the net learning system. So when you register for the class, I'll go in with the attendance sheet afterwards and complete the class, so your CEs will be in your completed folder for today's program. Also, make sure you fill out the evaluation forms that we have in here and leave on the back or leave on the table when you're done.
So I'm Sandy Hansen. I'm a stroke neurologist. I'm the head of the program, the stroke program at United Hospital, and the head of the Telestroke program. So, and Liz, I don't know if you guys have all met Liz.
Hi, everyone.
Yep. So Liz is going to be our go-between, and basically Liz functions as a stroke coordinator, or for our rural sites. We call our virtual hospital, and so. Oftentimes in a hospital that's this size, with a lot of internal people devoted to the program, it's going to be a little different, and the role will be more a partnership with folks here rather than helping to lead the stroke coordinator kind of work. But so that's the two of us, and I thought I'd start by introducing you to the rest of the team. Before I do that, though, I want you to know that today is going to feel like it's just about the stroke code and, you know, figuring out this process and how we're going to work together when we're deciding on rescue treatment for patients. But really the relationship that we're developing with each other is broader than that. We are going to be your neurology coverage in the hospital, not outpatient work, but in the hospital. And so if a patient comes in a time frame or with exclusions that preclude considering the treatment options that we have to do rescue treatment, so TPA and mechanical thrombectomy, and they're a stroke patient and they need a workup, we're there to do consults that are on a non-urgent basis. So we will be like, you know, a neurologist that practices here face-to-face, you know, as much as we can. In fact, that's the way we've designed our service. Our service isn't designed for you to be a referral base to us. It's for us to insert ourselves into the hospital and become partners with you. In addition, in the last year, we've developed what we call a teleneurology service, which in our practice at United, we actually have 3 neurology services on call. We have an epilepsy doctor, we have a stroke neurologist, and then we have what we call a neurohospitalist who does more general neurology kinds of consults in the hospital. So we have 3 inpatient neurologists on at any given time. And we want you to have that same service. So our teleneurologist on call will be responsible for doing the non-urgent stroke work, as well as other neurological emergencies in the ER or, you know, hospital-based neurological problems. So not really designed for outpatient stuff, but so it's a robust neurological service that you're bringing on is what's happening. So I want you to, you think I need to be wired? Okay. There you go. Well, I'm just going to let it sit right there, and I'll stand in one place. All right. So meet the team. So the top row here are stroke neurology. Jay Monita you won't be seeing. She's our nurse practitioner at United. But the 3 of us are stroke neurology. Actually, Dr. Corey will do the stroke code work as well. And then during day shift. And then the 3 here, as well as Dr. Corey, do the teleneurology work for you during the day shift. And then we have a night shift where one of the 7 of us will be on call for stroke codes and answering questions and that sort of thing. So you'll see virtually all of us, and all of us, at least these three at night, they'll at least be engaged in stroke codes, but their primary role is more the other general neurology and non-urgent stroke work with you. And you know Liz now, and then Becky is our other neurology outreach liaison that works with sites. Liz and Becky's counterpart at United is Amy Castle. She's our stroke program coordinator. We have Denise, who is a stroke nurse clinician that helps to guide care and works with us on individual patients and continuity of care. We have some research staff. And then, you know, just to introduce you a little bit to what our program is, we have a neurosurgical service that's kind of unique in that a lot of comprehensive stroke centers now dealing with aneurysm care and hemorrhagic stroke have good endovascular care. That's something that's really grown, you know, embolizing arteriovenous malformations or coiling aneurysms, that sort of thing. But to the exclusion sometimes of really good open surgery when it's needed. And for very complex cases, it's going to be needed. So we have, in the world of comprehensive stroke centers, we have the gift of Dr. Nussbaum, who is just an incredible surgeon. We don't have to send complicated cases anywhere because he really does it all, even giant aneurysms in very complex cases. His nurse practitioner, Jody Lowry, and then he partners with the Gillette Neurosurgery Group to support our vascular program. His wife is also a neurosurgeon, Leslie Nussbaum, and she leads our radiosurgery program, which we sometimes require for our arteriovenous malformation patients that need radiosurgery instead of surgery or together with surgery for management of those kinds of things. And then when patients do require transfer from here to a higher level of care, and again, that will be more the hemorrhagic aneurysm type patients, we have a full team of neurocritical care doctors that man our neuro ICU, and then neurointerventionalists if there's a case that requires embolization, that sort of thing. Of course, we're going to be doing endovascular here with Dr. Rarandi, but our guys are there to support him. We have one other site like yours in our we call it our stroke system of care in Aberdeen, South Dakota, who is an independent interventionalist, one lone guy at a hospital, kind of like we've got here. And just even, was it yesterday, we did a quality review, and Jeff Lassig got on the meeting, and we went over cases and helped to teach. These guys have an incredible amount of experience. They're doing, you know, 300 cases a year. They're just really skilled, and they've been in it for many years now, with 90% artery opening rates. So they'll be a great resource to Dr. Arandi in helping to keep our quality here, you know, where we want it to be. So, the service, ER and inpatient telemedicine services, the Telestroke code is what we're going over today, but then I mentioned the non-urgent telestroke and teleneurology service. So that's an introduction to our service. Any questions about that or how we interact together? I mean, we'll get back to it a little bit more later, but okay. So we're here to talk about stroke, you know, and these are stats that you guys see all the time, you know, almost 800,000 Americans are going to have a stroke in any given year, leading cause of long-term disability and huge cost. And I think the key is in our situation that stroke in the Midwest, a third of the strokes present to a smaller hospital. So we can't say that all stroke, because now it's getting more complex to treat it, goes to a metro hospital. We can't say that anymore. Patients need care. And you know, I can't tell you how happy we are to be seeing the interventional service develop here so that, you know, we are able to deliver that care really rapidly to patients close to home. So the different kinds of stroke that can occur, of course, are ischemic stroke, where there's loss of blood flow to a part of the brain, pictured on the right side of that brain. And then vessel rupture, like an aneurysm rupture causing subarachnoid hemorrhage, or a small deep vessel rupture causing intracerebral hemorrhage. Most of stroke is going to be ischemic, 85%. You know, so the small percent we're talking about was, say, for instance, subarachnoid hemorrhage and aneurysm is like 5% of all strokes. So it's not the common one. And then there are many different kinds of stroke, you know, and again, with the service that we offer, it's not just about getting that initial treatment going. It's going to be pigeonholing what is their cause of stroke, what sort of ischemic stroke was it, and what should the best prevention plan be. So we're going to go over today the complexity of the treatment decision, getting back to just stroke code, initial decision in the ER, and the need for expertise for a stroke code. So in a sense, you know, this is going to be about justification for why we're working together as a team now. Talking about stroke treatment tools that we have to offer our patients, the aggressive treatment stance that we take, the nuances of stroke recognition, and then the time factor. So why a stroke code team, and how is it done? So this slide is getting pretty old like me. I started practice in 1992. I was in a stroke fellowship when the TPA study was just going on. And so you can see I've lived through the take an aspirin and call me in the morning time, you know, so it always seems exciting to me now, but to you guys it might be a little bit old hat to give TPA. But I'm going to just walk through the tools that we have and the evidence for it, just to give you an understanding of where we're at. It's been, you know, since TPA got approved in 1995 with this study, things have changed dramatically. I mean, it took a long time for people to accept TPA in the emergency room. And now that things are really getting going, the whole picture of when and how we use the TPA and mechanical thrombectomy has really changed a lot. So our first evidence that we had was that initial NINDS study that showed an 11% absolute increase in very good outcomes. So that MRS that you'll see a lot, and you know, sometimes you'll see it in our notes, called the modified Rankin scale, and it's a scale of disability, 0 being nothing left of the stroke, 1 being maybe a little something left, but it doesn't cause any disability. And on the other end of the scale, 5 is, you know, extreme disability, and 6 is no longer with us. So in order to get people to what we call a cure, modified Rankin scale of 0 or 1, it only required 8 people treated, which is huge. And if you look at later studies of TPA that were done, and you ask the question a different way, not how many cures are we going to get using TPA, but how many people are going to see some improvement on that disability scale. And moving from a 4 to a 3 is huge. That might be the difference between being able to walk independently and not, or you know, being able to talk or not. Huge changes with 1 point change in the disability scale. And the pooled analysis of all the TPA trials said number needed to treat was between 2 and 3. So that's huge. So I use that data when I consent people in the emergency room. I say it's maybe a 30 to 50% chance you're going to see some improvement with the drug. It's not 100%, but that is a good result for stroke. And that's just TPA. So then finally the ECAS study in 2008 got published, and that showed that we had some benefit way out to 4.5 hours. It wasn't just a 3-hour time window, but you know, the benefit is dropping over that entire 4.5-hour time frame. So what about intra-arterial therapy? Well, what we know about strokes in large vessels, like the middle cerebral artery you see pictured here, use my little pointer, that if you're using IV alteplase for a larger stroke like this, in some earlier studies, if the clot is here at the top of the internal carotid artery, that can be a bugger to get rid of, and maybe only 10% of internal carotid arteries are going to get opened by IV TPA, and maybe more like 25 to 40% when it's in the middle cerebral like this. So, you know, enter mechanical thrombectomy. Well, all during that time frame, so TPA approved in 1996, and interventional trials were going on right along with the TPA trials back in the 90s, and then beyond. And what they were seeing, these are consecutively over time, these different clinical trials, that, okay, if this is IV alteplase artery opening rate, here's the artery opening rate when we start to put, you know, intra-arterial work to large artery problems, now to the point where with penumbra and solitaire, or the kind of suction device, or a stent retriever in the case of the solitaire device, those are opening these larger arteries in a rate of 80 to 90%. So, and that's in clinical practice, not just in these trials. So we had evidence that we could open arteries, and you would think, okay, well, that's the goal, right? But we didn't have evidence, surprisingly, until very recently, that opening the arteries resulted in a better clinical outcome. And the reason it's important, the difference between opening the artery, if it takes longer to open the artery and the brain is already dead, you really haven't done anything for them. So we really needed to prove that clinical benefit. There was hints, of course, that there was benefit, but until 2015, these 5 trials showed that if, these are called bridging trials, so they weren't intravenous TPA versus interventional treatment, it was intravenous TPA versus intravenous TPA followed by mechanical thrombectomy. Because they couldn't justify not giving people TPA that they could get going in a short period of time, and they knew it was at least somewhat effective. So this was for large artery problems, and what they showed is that doing both together was better than TPA alone. And so just point out the important, here's the control of the patients who came to a modified Rankin scale of 0 to 2, and here it is when you ended up doing a combined. So huge differences, and I can't tell you how hard it is to take an effective therapy, which TPA was, and make an improvement on it. So this was clearly something that needed to be part of practice. So after this, endovascular was no longer considered out there, you know, and maybe on the experimental edge, it's standard of care, and we need to do it. So you can ask the question, well, if it's so effective to do both, why don't we just you know, go straight to mechanical thrombectomy for those cases? Well, only about 30% of our patients that are treated with some sort of rescue treatment are actually candidates for mechanical thrombectomy. So if you take all the patients that are going to qualify for some sort of rescue treatment in the ER versus aspirin, so and a big chunk of them, 60 to 70%, are going to have too small a blood vessel to get at with a catheter. So IV TPA is where we start and stop. So we'll never be rid of the IV TPA. So it will always be important to have a team process where we're getting, even in sites where we don't have endovascular, all of our other rural sites basically, other than Aberdeen, we jump in and we give TPA at the site. There's no reason to be transferring patients prior to treatment. We need to get TPA going, and then we bring them in for their endovascular. And in the case here, we start IV TPA while we're bringing Dr. Orandi in, is the idea, even if the TPA is still infusing while we go into the procedure. So, and every once in a while, we'll find then that the TPA did the job. And we do the angiogram and we're done. We treat it overnight and we're done. So just to kind of make it clear to you that, you know, endovascular isn't taking over the world here as much as it did in the case of cardiac disease. We have new data too, going beyond 4.5 hours now, showing in these 2 studies that endovascular alone, we don't have any role for TPA beyond 4.5 hours yet. There's you know, we stop at 4.5 hours with TPA. But endovascular may be beneficial for those patients with large artery stroke that present too late for TPA. So, and we knew that. We were treating out to 8 hours or wake-up strokes, that sort of thing. But a year or so ago, these 2 trials reported out and said, hey, you know, if they've got favorable imaging for it, they haven't already evolved the stroke, go ahead and open the artery because it's going to help them. So, and this is with each, I just came back from the American Stroke Association meeting, and with each new study, this is widening a little bit too. And there's going to be, you know, even with imaging that we might not have treated before, we're gonna probably be wanting to do endovascular treatment. So this is gonna be a moving target with more patients even qualifying. So right now our stroke code, because of these two new trials, is a 24-hour time window. You call the code, is it a large blood vessel problem? You know, they're 10 hours out. What, does the imaging look favorable? Call in Dr. Arati. Okay. All right, so here, just to show you an example of a bridging case, what it'll look like. So this is a very old case back before we even had some of the tools we have with endovascular, but we were doing some things. She came in with speech difficulty, right face, arm, and leg paralysis. She had a clot sign. That's what this is right here. So that's clot inside a blood vessel right there, indicating this was a large blood vessel blockage. And at the time, even before we were, you know, this was when endovascular was the experimental edge. We looked at that clot. We said, there's no way TPA is going to dissolve through that whole long string of clot. So we called in our interventionalist right away, gave IV TPA, and she's taken to the cath lab, still occluded in spite of the TPA, so you can see the tip of the catheter, and then after the procedure, the vessel's opening up. She had a Lazarus-like recovery, immediate improvement in her speech and weakness when this artery was open, no stroke symptoms or disability, so she had a modified Rankin scale of 0 at 3 months. So what she was threatening to do was to take out this whole territory here, and she just took out some deep territory, and that's it, and it caused her no disability over time. So that's what we want to do for people. All right, so you can see now it's, when TPA got approved, I thought this is a recipe, you know. Here are the criteria for treatment. Everybody can recognize a stroke in the ER, right? And all we have to do is look at the CAT scan, and then we can say, no blood, okay, give TPA. So that was 1996. We're not in 1996 anymore. It's a complicated treatment decision, and that's why you guys are getting us engaged to help with all those things, recognizing the stroke, triaging the best treatment plan, reviewing the imaging together with radiology to determine what to do. So right now, you know, instead of just a non-contrast head CT, we have additional imaging. We won't be using perfusion imaging. This is MRI perfusion. It's a blood flow picture in most cases here, but we will be using CTA. So we'll be doing a non-contrast head CT to make sure there's no blood, look for early evolution of the stroke, and then we'll do a CTA that shows, do we have a large blood vessel blockage, or is there no large blood vessel blockage? And that will help to guide us to IV TPA alone, or, you know, a combined approach, or intra-arterial alone, whatever it is we think we need to do based on their clinical presentation and this vessel imaging. So, you know, it isn't an easy sort of mix of things anymore. We have to, you know, sort through their exams, sort through their history, sort through imaging, and if we have a goal of door to needle of 30 minutes, that's a lot to do, you know, that requires expertise in a short amount of time. And that's why telemedicine came into the picture. How do you do this complicated treatment decision, review imaging, do all this, getting the whole team process to get all this done and be able to make these decisions. So. Okay, so that's, you know, about the imaging. So again, this is kind of justification for why are we working together as a team, and why do you need why is it not good enough to have just a telephone call with us? And you can see with all that we need to do that's not going to be enough. So here are the previous exclusion criteria, and as I was mentioning before, you know, we had sort of a narrow group of patients that qualified for TPA when it was first approved. These were the original criteria, but that has changed in, I can't remember, I think it was maybe 2016 when a new criteria came out. And we had been practicing like this already, but this was now collected evidence over some years. The American Stroke Association, you know, came behind, you know, this kind of an aggressive practice and said, it doesn't make any sense to follow these criteria anymore. These were set up for the purposes of running a study and to have a certain population that you were treating. So, for example, seizure at onset. Well, why did those patients get excluded from treatment? Well, because you thought maybe it was a postictal TODS paralysis and not really a stroke. And so in a study situation, they didn't want to expose those patients to the study and have it ruin their study. Well, why in the heck now, with all the imaging that we have, if you see that it's a blood vessel occlusion, I don't care if they had a seizure at the onset of their stroke, it's a stroke, you know, treat it. So there's all kinds of things like this riddled throughout that now we have kind of, with new treatment options that we have, we can get around some of the systemic bleeding risk issues. So maybe we can't give TPA because their INR is 2.2, fine, take them to mechanical thrombectomy then, we can do that. So these original criteria that maybe have sat in your ER in the past aren't really being used. One that was commonly being excluded, and this is one I want you to pay really close attention to in the ER, is this idea that if you have an improving stroke or if it's really mild, it's probably going to be a TIA. So let's not treat because they're getting better on their own and we don't want to expose them to the risk. Well, here's a good example of a case like that. 84 years old, last normal about 10 in the morning, found by your daughter at 10:20 to have weakness and language disturbance. The medics described an aphasia and a right hemiparesis, gaze deviation, but by the time she got to the ER, that had just like disappeared. This was actually my case quite a while ago, and I went and I did my aphasia exam, and she was fine really. But when her daughter came in and she said, that's not my mom. You know, she's not talking enough. My mom is always talking in 1,000,000 miles an hour. So the fact that her language, when I went back and forth with her, was okay, was still not her mom. So I, okay, well, let's look at an MRI and just see what's going on. And sure enough, she had an M1 occlusion. She had a huge vessel occlusion. So in spite of the fact that her deficit had skinnied down to something really subtle, she still had a very threatening stroke going on. And you could see a tiny little bit of stroke injury evolving up there already. So we gave her TPA. And she improved, and the next day, 24 hours later, you could see these vessels filling out, but there was still a little residual clot there. This was back in IV TPA alone days, so we really didn't have endovascular options. And you can see that she had this small little stroke injury where she was threatening, again, to do this whole thing like our other patient. So, so mild and rapidly improving stroke can be, especially when they go from a big deficit and they rapidly improve, they could still have an occlusion there. So you don't just slam dunk treat all those patients. You look for a vessel occlusion if truly their NIH stroke scale is 0. I would treat someone if their NIH stroke scale was 0 and they had this middle cerebral artery occlusion so that I knew they were going to get worse later. But let's say they improved to something mild left over. I would still treat. I mean, even if that large artery opened up, that clot travels distal and is in distal branches, and they might have improved a lot, but they still have clot yet to dissolve. And those mild deficits can be disabling for patients. And in fact, about 1/3 of the patients in studies that have looked at patients who presented with mild stroke, and they were excluded from getting TPA, about 1/4 of them leave the hospital with significant disability. They don't get discharged home. So we kind of looked at this as a group a few years back at the Alina system. So 5 neurologists, all interested in stroke, got together and reviewed the data on should mild stroke be treated with TPA, mild and improving. And we came to this conclusion based on the data available. American Stroke Association, it was like months after, you know, all this work we did reviewing the data, American Stroke Association came out with those new criteria that I'm going to go over with you, and this was one of them. And it was basically mirroring what we said here. So we feel like it's really strongly supported since we reviewed the data ourselves. But patients who present within an appropriate time frame that are mild or rapidly improving, but they have some sort of continued deficit that you would perceive as disabling. So disabling for me would be, my hand isn't working. You know, they can walk into the hospital, they're talking, my hand isn't working. They can't do things that require 2 hands anymore. So it's worth it to treat that patient. a case that might be non-disabling, and actually even these are under study right now to determine whether or not cases like this would be appropriate for TPA, is maybe someone with just facial numbness and nothing else. They still have a deficit, but it's really subtle. You might consider not treating those. I can tell you there's going to be a little bit of variability on the decision making in this area between, you know, providers in my group and between my providers and others, you know. So it's a little bit of a flexible sort of recommendation, but. And then like our patients who present within an appropriate time frame with mild non-disabling stroke symptoms should be considered strongly for IVTPA if you can see a visualized vessel occlusion. So in our case, clearly that patient needed TPA. Okay, the other area that we would have excluded out of hand in the NIH trial was wake-up stroke, because we didn't know when the symptoms started. That was the NIH stroke study was really strict that way. If you didn't know when things started, you had to say when were they last normal, if it was when they went to bed the night before. But this is an area of active study as well, and I fully expect, we've got some initial data suggesting that maybe there's going to be a population of wake-up stroke patients that we'll treat with IVTPA, but we still have data out there, and evidence in favor of treating those patients with TPA is pretty limited. So right now, and some of it contradictory, we don't usually use TPA. You know, again, on occasion, people are going to be a little bit fungible in this decision making, but for the most part, we don't. However, if they have a large vessel occlusion, because of the data I showed you before, with the new study saying we might have a time window out to 24 hours with favorable imaging, if it's a large vessel occlusion, we're calling in Dr. Arad to help them out. Okay. So I'm going to go through this really quick with the provision that, you know, we have. Do you have that? Procedure about this. You have kind of a summary of it there on top. There's also more detailed telling you, trying to get some of the nuances of those changed inclusion and exclusions in there. But I'll go through some of them in a little detail so you can see how difficult it is to say out of hand, no, this group can't be treated and this group can. So, for instance, intracranial and vascular issues. If it's a brain tumor, if it's an intraaxial brain tumor, that's like, you know, a glioma, a primary brain tumor, a metastatic tumor, those things are going to bleed. We can't treat those. If it's an old, you know, extraaxial meningioma, no problem. They really don't have a propensity to bleed. So again, you know, you think about what we need to do in a 30-minute time frame to include or exclude people from treatment, and going over a scan and saying, yep, this one's okay, nope, this one, please don't give them a TPA. It's important to know those differences. Brain arteriovenous malformation, uncertain, you know, depending on the stroke severity and, you know, how big is the AVM. So again, you know, it's not a slam dunk question. Unruptured aneurysm, definitely. Most of those are, you know, I mean, if you put it in perspective, about 3% of us are walking around with an aneurysm that we don't know about. Make you a little nervous. So, yeah. And so you're going to have people coming in, we do the non-contrast head CT, we give IVTPA, and, you know, we later find out they have a 2-millimeter internal carotid artery aneurysm. There's no reason why that aneurysm is going to rupture right at the same time you're giving TPA, and the TPA doesn't make it rupture. So it really offers no additional risk, unless you're talking about a leaky, giant, ugly, big thing in the head. You know, those things I wouldn't give TPA to. So again, you know, it's going to require some review of imaging and some discussion before proceeding. Dissections, people, when an artery tears the inside wall, it's a young person's cause of stroke. That flap that develops inside the vessel because of the tearing of the inside of the wall causes clot formation there, and they have a stroke. For a long time, it was the concern was that you're going to make the dissection worse with TPA. No. If it's a dissection from here up, if it's a dissection in the aorta, don't do it. Yeah, so again, it's yes and no. And I could go through all of these. We used to exclude MI completely, but if it's subacute non-STEMI for sure, and subacute left inferior STEMI, but if it's a left anterior STEMI and subacute maybe, it just kind of depends on the situation. So it's no longer, what it used to be where we were concerned that, the biggest concern was if you were treating a subacute stroke, if there's a little bit of pericardial fluid from the injury, or you have a transmural injury to the myocardium, that you're going to cause bleeding into those areas. So, and now with collected evidence, we can treat most of those without worrying about it. Infective endocarditis is going to be a different situation. You have infected clot that's gone up to the head to cause the stroke, and it makes the vessels fragile, and those are likely to bleed. And also, they usually present in a subacute fashion, so they come in for their stroke, but they've had 2 or 3 in the weeks prior because they've been embolizing from their valve. So it's not a good idea to treat those cases. Systemic medical conditions, why we wouldn't treat someone who has dementia, if it's mild or moderate in particular, and they have some quality of life, why should they have to live with a hemiparesis that, their counterpart without a dementia doesn't? No reason. I think a lot of this stems from the clinical trials where they said, we're going to exclude these patients because it'll be hard to figure out whether or not they gain benefit because their modified Rankin scale is already bad. And so how can we show improvement? So it's, a lot of these things, are things that were concerning in the very beginning and no longer are concerned. And again, I won't go over all of these, but sometimes, with some of these systemic bleeding risks, I might have to call up a surgeon and say, what do you think about this, depending on how invasive and deep the surgery is and what's going to happen, if we have bleeding, at the site of their surgery. Is it controllable bleeding? And which is more important in this case, is it the brain or, the knee? Well, if it's a really mild stroke, maybe the knee, So we have to make sure that we're making logical decisions, and sometimes we pull in other providers to help us with this. Same thing with all of this stuff. So again, I'm sorry to skip over that fast, but you can see it's really nuanced. So there's the list to give you some guidance, but we aren't asking you in this process to triage a patient and say, oh, they've got this thing on the list, let's not call a code. We say, call a code if it's a focal neurologic deficit within a time frame, and that's it. The rest of this stuff, we sort out together as a team, so during the code process. If we don't do that, we're going to miss cases, and we're going to slow down their treatment. So here's our triage plan. 24 hours. If treatment can start within 4.5 hours, and we determine either by their exam or images or both that it's a small blood vessel, it's not amenable to mechanical thrombectomy, they get IV TPA, they go up to the ICU. If it's a large vessel problem, we start with IV TPA if they're in this 4.5 hour time frame, and follow it with mechanical thrombectomy. If they have some sort of reason why we can't do mechanical thrombectomy, or let's say it's a 92-year-old with some dementia and the family says, we just, we're willing to go the easy route, just, give an IV drug, but we don't want to put them through this big procedure. Sometimes that will happen. We might just go with IV alteplase alone.
Does the mechanical thrombectomy have to happen within that 24-hour period? Or it just needs to be determined that it has to happen?
It has to happen
prior.
as quickly as possible.
Okay.
Yeah.
Okay.
Yeah, I mean, the studies of the bridging trials where they were comparing IV TPA to the both of them for large artery problems, they had to get the TPA within 4.5 hours, and then, so these were all patients presenting earlier, and then they had to get the mechanical thrombectomy started within 6 hours. So, I mean, that was criteria of the study, and that's how they showed benefit. So we have to be the same. So it's a very good question, because 20 minutes into the code, I'm knowing that I've got a large artery problem. So I'm asking you guys, let's get Dr. Randy, and we're going to need both for this one. And so we get the mobilizing as soon in the code. We don't wait to see if they're going to improve with the IV TPA first, yeah. And then the example I gave earlier, you might have someone who's on warfarin and their INR is therapeutic and we can't give IV TPA if it's above 1.7. So then mechanical thrombectomy alone. If treatment's going to start after 4.5 hours, but within 24, and it's a small vessel problem, right now aspirin's what we got. You know, again, you know, we'll keep you posted as some of these wake-up stroke studies come forward and you know, other things are reported out. But for now, it's a 4.5 hour time window for TPA for small vessel problems. Large vessel, mechanical thrombectomy if the imaging is favorable. Okay, so any questions about that as a protocol? Decision-making protocol. So now I'm bringing you back into triage. And again, this is, why do we work together as a team? When I started out in my practice, I thought a stroke is a stroke. I can recognize, anybody can recognize a stroke, you know, in the ER. But as, you know, this was 1995, and my neurology practice at the time, before TPA got approved in 1996, I didn't go down to the ER. It was an ER doc that was there, and I didn't see the stroke until a day later, and, you know, I would say like, oh, how could they miss this aphasia? Well, you know, I wasn't down in the ER and seeing what they saw, and I wasn't triaging, and I could see how they missed it once I started going down to the ER. So over time, what I discovered as I spent more and more time in the ER developing my stroke code process at my first hospital where this was an opportunity, I found large artery strokes that were getting missed regularly because they presented in just not a typical fashion. So I collected these, you know, some of this, you know, these cases are a little old, but it's still relevant, unfortunately, because we still miss them. So what we're going to be saying to you is cast a wide net, and we'll skinny it down to the ones that are really stroke and the ones that are available for treatment. So in our code process, you might call 5 codes for one patient you treat. So, and that's great. You know, don't worry about your mobilizing our team too much or something like that. This is the way it is at every single hospital we work at, including our own. So, one case, anterior cerebral artery serves this tissue right here. And if you remember the homunculus in your anatomy class, right between the hemispheres is where your leg sits. So if you get anterior cerebral artery, it might just be sudden onset leg weakness and numbness, or maybe just weakness, depending on how far back it goes if it gets into parietal tissue. And it'll get mistaken in the ER triage area for a pinched nerve in the back, but it's painless, so it shouldn't be a pinched nerve, you know. And sudden in onset, you know, that's not how pinched nerves present. So awake unresponsive, this is less common. Honestly, I gotta say I've seen it maybe 2 or 3 times where they presented where they had the anatomy where here's your internal carotid, there's your middle cerebral, here's your anterior cerebral that serves that tissue. And in some people, both of their anterior cerebrals come off of one side. So they basically, with their stroke, if they get that clot right in the parent artery of that anterior cerebral, they get a frontal lobotomy with their stroke. And they're just like, you know, awake unresponsive, I call it, or ebulia is another name for that. And could potentially have both legs weak, just depending, again, on how far back that anterior cerebral distribution goes. So it will look to me like a seizure. It looks like someone having a complex partial seizure, a staring spell. You know, so you know, if you have someone with sudden onset, they don't have a seizure diagnosis, sudden onset, just staring off in space, you know, think about it. I mean, there's nothing lost in doing a CT and a CTA to prove. This is going to be obvious on a CT angiogram that they've got a big vessel occluded. Okay. All right. Oh, you know, I didn't check to see if this is going to work. Hopefully it does. Okay, this is aphasia. Isolated aphasia, no hemiparesis with it. You know what I can do maybe here is just get on the internet.
I think if you pull it back up, it was on the other
Oh,
window.
really?
So go back to your Explorer on the bottom.
Your blue tape measure, there it is.
There we go.
And then
Slide.
right up to it's all the way up.
Play it.
I can hear it.
Shake hands for me. It was happy. I would talk with Donna sometimes.
Okay, I'm gonna.
We're
take
out
this
with them,
back.
other people are working with them.
This is a guy who, he's later in his course, obviously, but
We stayed with the water over here at the moment, and talked with the people with them over there. They're diving for them at the moment. They'll save in the moment. He'll water first and for him. Good luck for him.
So we're on a cruise and we're about to
We
get
will
to
sort right here and they'll save their hands right there for them.
And what were we just doing with the iPads?
Right at the moment, they don't show a darn thing.
With the iPad that we were doing, like here?
I change for me and change hands for me.
has no idea what she's
With
saying,
that.
right? He's coming up
Talk
with
with Donna
answers, he thinks he
sometimes.
knows.
We're out with them, other people are working with them. I'm very happy with them. This girl was fairly good and happy, and I play golf and hit other trees. We play out with the hands. We save a lot of hands on hold for people's rights, other hands. But what you